Thank you, Chairman. Good afternoon. Let's go to introduce the pediatric trauma. Trauma is a leading cause of morbidity and mortality in pediatric age, and in 80% of cases is due to blunt force trauma. Most common causes are motor vehicle crashes, car versus pedestrian injuries, and falls. Less common causes are sport accidents and intentional trauma. Regarding the differences between pediatric trauma and adult trauma, children have higher body surface on body volume and therefore higher energy applied for body surface unit. Children have less amount of connective and fat tissue, less internal organ distance, have more elastic tissue and more bone flexibility than adults. And therefore, organ injury can happen without bone fracture. And in case of rib fractures, we must consider high energy transfer to internal organs. In every case, in children, always consider all organ injuries. Children have smaller blood vessels with enhanced vasoconstrictive response, and therefore bleeding associated with solid organ injuries often stops spontaneously in pediatric age and allows a non-operative management. Clinical evaluation in children is difficult and challenging, and imaging plays a key role in the assessment of injured child. Imaging techniques are X-ray, ultrasound, CT, and in the last years is improved the use of CEUS, contrast-enhanced ultrasound. We have two big categories, two big clinical situations. The first is the hemodynamically unstable patients that perform in shock room, chest X-ray, and fast sonography to diagnose hemopneumothorax sound or hemoperitoneum and to undergo thoracic drainage on laparotomy in emergency setting. In these patients, ultrasound has many advantages, can be performed at the bedside of the patient, can easily demonstrate hemopneumothorax or hemoperitoneum, but has also many limits, as a poor sensitivity and specificity, and poor accuracy in detection of solid organ lesion, or quite no accuracy in detection in injuries of the pelvis, of the lumbar spine. In this emergency setting of unstable patients, the use of ultrasound is on the fast focused assessment sonography for trauma in 4 anatomical regions to search for free fluid in abdomen that indicate the necessity of emergency laparotomy. The second clinical condition is that of hemodynamically stable patients, and we can have two different presentations as patients with high energy trauma and patients with low energy trauma. We begin from high energy trauma. In high energy trauma, the CT is the radiologic standard for evaluating trauma patients, has many advantages as injury accurate, injury detection and grading, whole body examination. It can diagnose not only lesions but also prognostic indicators. But as some disadvantage as radiation exposure and the administration of iodinated contrast medium. But we must remember that CT is mandatory for the evaluation of every high-energy trauma patients. Let's go to the second clinical presentation, the hemodynamically stable patient with low energy trauma. In these cases, we have the use of US and X-ray. I said a few minutes ago that ultrasound has many limits in trauma patients, but with the use of contrast medium, with contrast enhanced ultrasound, CEUS can overcome these limits. What is CEUS? CEUS is a technique well known that has a good diagnostic accuracy in detection of traumatic organ lesion, both in adult patients and pediatric patients. There are many reports in literature that CEUS has a good sensitivity in detection of trauma patients. CEUS requires adequate ultrasound technology, a contrast-specific software, 2 bolus of second-generation blood pool contrast, and abdominal scanning of 3 consecutive minutes for each bolus. This slide shows the sequence of abdominal examination with CEUS, beginning from the kidneys and ending on the liver and the spleen. CEUS, this is my staff, that I give them my acknowledgements. CEUS is more sensitive and accurate than baseline US, and it is similar to CT in the identification and characterization of solid organ lesions. It is a useful and cost-effective tool in assessment and monitoring of blunt abdominal trauma in children. And CEUS should be considered for the study of hemodynamically stable patients with history of low-energy abdominal trauma. The lesions of the abdominal organs, the liver is the most frequently involved organ in blunt trauma. Lesions are parenchymal laceration, hematoma, parenchymal or subcapsular, hemoperitoneum or hemoerythroperitoneum, and then vascular injuries that are rare in children. The goal of our examination is to detect the extent of parenchymal disruption, the capsular involvement, the presence of fluid collection, then the active bleeding and vascular lesions that are not well diagnosed with CEUS but with CT. This is the first case. You can see in this slide a baseline US that shows a normal appearance of the left lobe of the liver. The CEUS can demonstrate a subtle laceration of the left lobe that is well confirmed by CT. One more case. In this case, baseline US shows a linear laceration of the right lobe, but CEUS demonstrates better the shape of the lesion and the capsular involvement by the lesion. And I ask you to see the perfect correspondence with the shape of the lesion and the extent of the lesion by CEUS and CT scan. This is a newborn with a decelerative trauma, and clearly we performing also in the newborn CT. This is a young boy, 16 years, with a lesion evident just on the baseline US, clearly depicted on CEUS and on CT. In this case, very interesting, we have hepatic hematoma on the baseline US and a subtle fluid collection, perisplenic fluid collection, but on CEUS, the lesion, the laceration on the liver is clearly depicted and is clearly demonstrated the perisplenic fluid collection. But on CT scan, we can see the active bleeding evident in the CT venous phase. In this other case, the lesion is not clearly demonstrated by baseline US. It's evident on CUS. You can see that on CT scan we have an intraperitoneal active bleeding. The same active bleeding in this case is evident also in CUS. You can see here. Let's go to the spleen. Also, the splenic involvement is frequent in blunt trauma. Lesions are laceration, linear or branching, and complex injury as shattering or fragmentation. CUS can clearly demonstrate the first 3 grades of injury, while in 4th grade, CT is better to detect the vascular involvement and the active bleeding. This here has some cases. A baseline US not very well demonstrate inhomogeneity of splenic ecostructural surface, while in CUS we can see the splenic laceration, and it is confirmed by CT. In this case, very particular case, we have a baseline US that shows a apparently normal spleen. In CUS, we have 3 different focus of trauma in the spleen. That is confirmed on CT. It was a sport trauma in a young child. One more case of splenic lesion, and the perfect correspondence anatomical and as the extension of the lesion on CUS. Kidneys are the 3rd most frequently injured organ in children. Normally, the involvement of kidneys is in case of direct impact, and most frequent lesions are parenchymal contusion, laceration, and perirenal hematoma that are well seen on CUS. In decelerative trauma, the vascular and collecting system injuries can be depicted more clearly by CT. Here is a case of renal trauma with a poor diagnosis on baseline US, but clearly depicted on CUS with perirenal hematoma. Here is a horseshoe kidney, the picture on CUS, the complete fracture of the middle of the horseshoe kidney, confirmed on CT. And in this case, we have on baseline US, we can see a perirenal hematoma and the clots within the bladder. CUS shows the complete fracture at the middle of the kidney. That is confirmed by TCT, the perirenal hematoma, the kidney fracture. CUS don't say nothing about the collecting system injuries, but in the delayed CT scan, we can see the fracture of the renal pelvis and the urinoma, the leakage of iodinated urine. Pancreatic injuries are rare, but relatively more frequent in children. The lesion mechanism is the compression of the body against the vertebral column, and the lesions are laceration, transection, or pancreatic collasion. This is a case of my personal experience. Ultrasound diagnosis of pancreatic injuries can be difficult. We can see more easily fluid collection located anteriorly to the pancreas. And in this case, we have a poor diagnosis of the pancreatic lesion, but is depicted by CT. Due to the rarity of pancreatic injury, there have been very few reports on the use of CUS in pancreatic trauma. This is a case of my good friend Massimo Valentino that shows the pancreatic tail, not evident lesion at baseline US, but on CIUS you can see a little laceration of the pancreatic tail that is confirmed on CT, and it allows to say that CIUS is useful in pancreatic lesion, perhaps better in follow-up than in first diagnosis. The bowel and mesentery lesions are relatively uncommon in children, and the clinical signs are absent or delayed, and ultrasound is very poor in the diagnosis and only can demonstrate the presence of free fluid. This diagnosis is often performed by CT with specific and aspecific CT signs. In conclusion, the baseline US has a poor sensitivity in the diagnosis of solid organ injuries in blunt abdominal trauma. CIUS is an accurate diagnostic tool for evaluating stable patients with blunt abdominal trauma. It is indicated in case of isolated blunt abdominal trauma and low energy trauma in pediatric patients. CIUS limitations include intestinal injuries and the evaluation of prognostic indicators as vascular involvement, active bleeding, and collecting urinary system lesions. CT remains the main diagnostic tool in high energy trauma due to the whole body exploration and the high risk of multi-organ injuries. And ending my lesson, I invite all you in the next Congress of the EASIR, European Society of Emergency Radiology, that will do in Vienna in June. And thank you very much for your attention.